and then use it by the skull coast technique. This is how this technique can be used, and you can see that can be fixed with a screw. That screw should be sunk in, and the screw should not touch your base plate. There should be a cement mantle between your base plate and the screw. So this is one patient where you can see that a patient of varus deformity. This was a defect which intraoperatively we saw, and then this defect was packed with the bone grafts which are taken from the proximal tibial cut as well as the distal femoral cut and fixed with screws. So this is a good technique where you don't need access to allografts, and you can use the bone graft which is harvested from the cuts itself. And at times you can also use the metallic augments. The problem with metallic augments in these cases that the augments are a little expensive, and they can cost anywhere between 15 to 20,000 rupees for one augment, and therefore using autografts which are readily available to you is a good idea rather than using metallic augments. Another disadvantage of metallic augments is that you've got to cut your bone to the size of the augment. So at times you tend to remove more bone than what is required, because that normal bone has to be removed so as the augment can fit exactly into that defect. We can also use femoral augments, and this can come along with the processes. As we go with higher constraint, we can put these augments very easily, and you've got to size the exact augment which you are going to use, and the rectangular is actually better than the trapezoidal. So this is the patients where the patient had a severe varus deformity, and the patient also had a pathological fracture along with the varus deformity, severe varus, and this is, you can see the kind of bone defect which is there, which we had to reconstruct. I'll just move on. This video is not playing. It actually shows the defect and how we took the cut. And this is a rectangular slot technique. This technique was described by my father, K.H. Suncheri. And you just make a rectangular slot and you put this particular wedge inside, as you can show. And this fills up the defect. And this is how it is put in by a press fit technique. The technique is the press fit. It goes inside, and then you fix it with a screw. This was the post-op X-ray. We did a bilateral, and this was the follow-up at 1 year when we did the case. In cases of severe deformity, especially in revision cases, it's beyond the scope, but I just thought I'll quickly mention that the type 1 are quite easy to handle, but the type 2 AORI and the type 3 are the difficult ones, and these are the cases where you have to keep cones and sleeves ready. The type 2 and type 3 where there is severe bone loss, then you've got to use the sleeves and the cones. Both have separate indications, and the cones, the trabecular metal cones, are becoming quite popular, and they can be used in revision cases, and they have a very good bone affinity and get incorporated. And when you use a sleeve, that has to be used along with the implant. But when you use the cone, it can be independently used to first, see the bone defect, put the exact size, and then you can put your components on top of that. So I think the important things whenever we are tackling bone defects is that please remember that don't resect too much. Bone is the best substitute, and you can use it from your cuts. Also, where it is important that whenever you're dealing with these defects, always use an extension rod. That is important. Keep in your armamentarium the constraint processes like the hinge process is ready. The last word which I would like to say before I finish, whatever reconstruction technique you may use, I think it is important to balance the knee well and align the knee well. If you do that, the incorporation of the graft will be perfect, and the patient can immediately start full weight bearing. Many a times after we do the whatever reconstruction technique to reconstruct the bone defect, at times if you've not balanced the knee well, and if your alignment is not good, that graft is not going to stay and not going to take. And therefore, it is important that along with whatever technique you use, you balance and align the knee well so that the patient will have a good outcome. I wish to thank KOA office bearers and Dr. Rajshekhar and Dr. Mallikarjun, for this opportunity. Thank you very much, Dr. Rajshekhar.
Excellent talk on that. So how often you use this, especially the sleeves or the cones you use in primary revision scenario?
To be honest, there was only one case I had used it for. There was a neuropathic joint, and for that particular case, I used it. Otherwise, apart from that one case, I have never used the sleeve. And also that neuropathic joint had a big defect, so that was the reason why I used it. Otherwise, never in a primary need. In revisions, it's a very useful tool to have.
Anything to add, Sir Jayant Patel,
sir? I would add is if you're going to use bone graft, make sure you use a stem. I think that's the basic concept. And almost any time you're doing anything other than a primary, use a stem. You can sometimes just do a press fit stem. You can sometimes fully cement the stem. But if you're doing anything other than a simple primary, use a stem.
But
mandatory.
But some certain knees like Zimmer or other companies where you can't, you need to have a go for a revision implant is a little concerned thing. You need to have a backup, otherwise it's difficult. Only the best is
that's a design flaw.
Yeah, PLC is the best advantage in that way. So,
I mean, every operation you do, even if you use a primary system that doesn't have stems built into it, you need to have something in your hospital in case a condyle breaks or something happens, and you have to put a stem on. You cannot do a primary operation with only a primary system in the hospital that doesn't have stems.
Rajshekhar, like Parag, hi.
Yeah.
And, I think that was a very nice talk. We've got plenty of experience using bone graft like you described and seems to work very well. We've had about 40 of them on a long-term follow-up now. There are no failures with that, provided you do the technique well. We almost never use metal wedges, almost never use them, and most of the time we are able to create a nice platform using the bone graft from the femoral condyle classically and put the screws in and hold it nicely. It's just a little awareness and a little practice of how to do this right, and then it will become a very quick procedure. It hardly takes about 8 to 10 minutes to do it once we get the hang of it. Yeah,
absolutely. It doesn't cost anything. It's free.
Comes in when you have to decide between cutting more tibia to removing the defect, or suggesting if I have to remove that much tibia, that's too much. So if that's that balance you have to weigh, and that's when occasionally the metal augments will come into play, or occasionally bone graft will come in play. But I would say 95% of the time, you just cut 3 or 4 more millimeters of tibia, and you cut the defect away.
Yeah. Dr. Amari, if I can ask you, downsizing and making the tibial platform a little smaller to accommodate the defect to go away. What's your experience with that? Anything? I mean, there could be a mismatch between the femoral and tibial components if you do that, but in the long term, have you come across any problems with that?
It works great, and it gives you the added advantage of allowing the medial side to be balanced a little better.
Yeah.
You have to know your system, so you have to know what the compatibility is between the different femur and tibial sizes.
Yeah.
In my diffuse system, I can go 1 up or 1 down. In another system that I use, I can go 2 up or 2 down.
Right.
It just gives you more flexibility in that regard. At this point in time, I don't think wear is a major problem, right? Wear is not why knees are failing. They're failing because we cement them in poorly, we put them in malaligned. It's most of the time it's our fault. It's not the implant's fault.
Anything to add, Deepak, Dr. Deepak? Sir?
Sorry, I didn't follow.
Yeah, sorry, I couldn't get your question, Rajshekhar.
No, anything to add any further to this?
No. It's very well done, Rajshekhar.
Dr. Chandramodi, sir? Yes, okay. Okay. Thank you, Dr. Parag Sancheti, sir. It is a wonderful talk in our webinar. Now, move on to Amar Ranawat. He is professor of Cornell Medical College, and also he is also he was presently a president of ACA, American Association of Hip and Knee Surgeons, and he runs a center in Hospital for Special Surgery. We go for training every year, so it is really lucky for us to expose to such a good opportunity. And I think he's going to speak on keynote on complex knees. So educate us about the ideas and techniques.
So are you going to run my slides, or am I going to run my slides?
If you can run, sir. If you
All right, so can you let me share?
It's better you run it, Amar. That'll so you have control.
Let me see how I can do this now.
You find somewhere share.
Share is there, front. There's a third one.
See my slides?
Yeah.
Not yet.
Yeah. Not video.
There's a third one after that video part.
It says open system preference.
You see down, Amar, there is one for mute, one is for your video, and then one arrow which shows the upward direction. So that arrow which is going up, just press on that, then it will allow you to share your content.
I know what you're saying, but I don't see what you got. I got open system preferences.
Need to move the cursor over the screen, then it will appear.
Somebody from the host should allow him to share, then only he'll be able to share.
Yes, I have allowed him. He is the presenter.
So he's the presenter, so then are you on Mac, Amar?
Yeah, I'm on a Mac.
That's sometimes an issue with.
KT, why don't you just play the first talk from Lessons Learned?
Yeah, you make him presenter, no Dr. Amaranth. You made him, okay. Okay. You are not able to see that, sir? No. You have to open up your PowerPoint presentation first, then you have to go, otherwise.
It's open. It's open.
Okay.
No, Shamiullah? Yes, doctor. Yes, doctor. Yeah. I think Amar is not able to share. We can move to the next presenter. By the time he can mail it to me, I'll present it from my thing.
Okay, I have his presentation and I'll make it this thing.
Yes. I'll make you as a presenter.
Yeah.
We have ready.
Dr. Rajshekhar, you can present.
Can you see?
That works.
Yeah?
Yes.
It can be seen very well.
So this is a presentation that I gave to the American Hip and Knee Societies. They asked us all to, everyone that had a son who had a father that was a surgeon, to give us what you thought you learned from your father. So I thought this would be a great talk to share with you guys. we've been going to India now for close to 20 years, all over the country, trying to teach this hip and knee operation. It's been a pleasure to meet all of you and to be part of your training. So it's an honor for me, and I am very proud of everything that you guys have accomplished. So I'm going to teach you what my dad, my guru, taught me. You can go to the next slide. These are my disclosures. They're not relevant to this. Next slide. Everything my dad told me, there were rules. There were 3 rules. There were 5 rules. There were lots of rules. But a successful surgeon follows certain principles. Next slide. Next slide. Nope, go back one. So this is what you need to be a successful orthopedic surgeon. It's a long list. It takes a lot of time and effort and energy, but it's all right here. You got to be a professional. You got to be certified by your country or your nation. You got to believe in the patient. You got to be held accountable. You got to give the best quality of care that you can and have good patient satisfaction. You need to study medicine in an evidence-based way. You need to continuously increase your knowledge. And that's what these meetings do for us, is that, you don't just sit on what you learned once. You constantly grow and grow your knowledge. If you grow your knowledge and you keep operating, you'll improve your surgical skills. Then you have to do research, educate, and publish. You need to build a good team. You can't do this operation by yourself. You need assistance. You need help. You need anesthesiologists. So the team concept is very important. At the end of the day, they want you to be a good leader. So be a good leader, and then don't forget, at the end of the day, the most important obligation that you have is to your family. Next slide. So I'll go through now a series of ideas that my dad had and things he read that always stood out to him. And this is one of the most important. Those who cannot remember the past are condemned to repeat. He'll say this over and over and over again. Don't make the same mistakes that somebody else has made. Next slide. When you have history, you have an opportunity to study, analyze, define, and document why that situation didn't go well. That's where you get your solutions to solve the problems of the day. When you can analyze, synthesize, put it on paper, document, success will become the dominant theme. At the end of the day, if you want to talk about the English, they were really good at 2 things. They were good at sailing boats, but more importantly, they were good at writing things down. If you don't write it down and put it on paper, it doesn't have any value. Next slide. Surround yourself with good people. Identify problematic issues, problematic people. Study, analyze, synthesize, and learn how to articulate your problems and your answers so your office, your employees, your team, and your patients can understand you. That is one of the most important things you can do for yourself. Next slide. At one point, I applied my father for the Nobel Prize for this prosthesis. It was considered. It's still being considered. So maybe he gets lucky at some point. But this changed the world. This knee device, it wasn't a brand new device. It wasn't a groundbreaking in the sense that no one had ever seen anything like it before. but he synthesized, and John Insull and Peter Walker, they synthesized all these available technologies into one. And that's what made it special and successful. Total condylar knee prosthesis, the beginning of knee replacement as we know it. Next slide. And it takes commitment. Nothing happens by accident. You have to meet every day, every week, go over these concepts and try to figure out all the issues that come up. And it's hard work. There's nothing like hard work to make you understand and appreciate how important it is. Next slide. Here's a big one. Don't be greedy. It's an honor and a privilege to talk to you. It's an honor and a privilege to take care of patients. We all get paid pretty good. Some get paid more. Don't be greedy of that. Don't be jealous of that. Because if you are, in the end, that will affect you and it'll cause you to make poor decisions. Next slide. You got to give back. God gave you a gift of a beautiful mind and a beautiful body. You have to give back now. You have to give back your knowledge. You have to educate. Sometimes you have to give back your money. So I think if you are lucky enough to be an orthopedic surgeon, you should be smart enough to know what the right thing to do is. Give back. Next slide. If you are successful and you surround yourself with good people, one day you will be part of the Knee Society. This is the American Knee Society. I know there are knee societies all over the world, in Europe, Asia, and that's the highest level of performance when you can surround yourself with colleagues who are as successful as you are. Next slide. You need to give back to the residents and the medical students, and you have to understand that every young doctor wants to be like you and wants to strive to be as good as you, and that's okay. If you teach them, they will appreciate it and they will honor you and respect you, not take your job. Next slide. The same goes for fellows. The same goes for Indian fellows and every country you go to. I realize now none of us are traveling. It's a crazy world. But I went to 68 countries last year. Just teaching everybody in all different languages, all different cultures. But everyone has hip and knee problems all over the world. Next slide. So when you give to the right people. We have given to the OREF, which is a foundation in the US for orthopedic research. We've given to our own hospital. We've given to the universities that we went to as children. We believe in regional foundations that take care of regional problems. And we've given plenty of money to the Indian Research Foundation, the Ranawat Orthopedic Research Foundation, as well as we funded the Ranawat Rothman Traveling Fellowship. So give back, as I said before. Next slide. So the next little bit will be just some sayings and things that my dad came up with that I always found spot on. So these are life-affirming principles. Nothing endures but change. So if you cannot handle change and you cannot adapt, you're going to be in trouble. Next slide. Everything in life can be improved. You have to believe that, and you have to make it true for you. Next slide. The only rational way to educate adults is by example. You can talk all you want, you got to do, and your children and your colleagues, they will follow. Albert Einstein was right. Next slide. Probably one of my favorite lines my dad ever said. Surgery is fun when you can see. Learn how to expose the hip, learn how to expose the knee, and you'll have a much better surgery. Next slide. The eyes only see what the mind knows. Things don't just appear in front of your eyes. You have to put them there. Ideas are born in the sweat and tears of hard work and perspiration. The eyes only see what the mind knows. Next slide. A surgeon should be bold in all sure things and cautious in all unsure things. That was written 300 years ago. Pretty spot on. Next slide. This is one of my, it's better to kill someone than to maim them. Let's hope we don't do either. Next slide. The only way to avoid complications is to not operate. When you take a knife to someone, it is a holy and religious experience for them. You must treat it that way, and you must recognize if things don't go the way you wanted, it's your obligation to, number one, fix it, and number two, avoid it in the future. Next slide. If you have to guess right. Don't be wrong, be right. Next slide. Back to what I said before, no amount of success in life matters if you fail at home. Don't forget your wife, don't forget your kids. Be a good dad, or a good mother for that matter. Next slide. Love your family. Enjoy those moments with them. Take the time to do it. It's something that will make them more successful if you spend quality time with them. Next slide. So in summary, you need to be an expert in medical knowledge. You need to have excellent technical skills. You need to apply maximum effort when the time calls for it. You need to have attention to detail, good communication, provide quality care, accountability, leadership, and that all is true for what you do in the hospital, but just as much what you do at home. I'm proud of every one of you. You guys can be great orthopedic surgeons if you use these ideas and apply them. So I'm happy to answer any questions and talk more about the actual operation in my next presentation. Thank you.
Oh. Thank you, sir, for your excellent, I think, motivational talk, and it concludes both the experience of senior and yours. It's really a wonderful thing rather than only reading about me. It includes everything. Your life perspective, also subject, also the family, everything. Thank you very much. It was a really wonderful thing to get motivated from you. Anything to add from?
No. I should say it's absolute pearls. Thank you so much for sharing that with us, Dr. Amma. It was lovely listening to that and feeling that passion with which you and your family have done such wonderful stuff for orthoplasty in general, and especially to our country. Orthoplasty really blossomed with you guys coming over here and teaching us all how to do this. Thank you so much.
Pleasure.
Thank you, sir. Next, we'll go to Dr. Sharan Patil. I think.
Can I ask one question?
Yes, sir.
By the time he loads up, so Amar, now is my chance to ask you something related to your talk. So you spoke, and I know how much your dad has contributed in your success. But the question is that what are the things which you did not do what your dad told you to do, and which you feel today are really helping you in your career? At times, and even my dad, taught me so many things, and I learned so many things. But there have been times when there have been, I call them debates. I don't call them fights. So which are the debates which you kind of think you won and which has helped you in your career?
Parag, just say you are rebellious.
I don't think you ever win in a debate with your father. That it doesn't work that way. Maybe there were a few ties, but you don't win. I think the point is, if you adopt a philosophy that is good at its core, it allows you to then grow as a human and as a surgeon, as a person. And so, most of the operations that I do now are not what my father taught me. My father didn't teach me how to use metaphyseal sleeves in revision knee replacement. I taught myself how to do that. My father didn't teach me how to do a non-cemented total knee replacement. I can talk on if you have time later. I taught myself how to do that. My dad definitely didn't teach me how to do a cruciate retaining knee, which I taught myself how to do that. So learning how to teach yourself, and it's learning how to grow and be, and that is what he taught me, even though he didn't actually teach me those actual techniques.
Okay.
Sir, do you have done both the PS, and substituting design and retaining house? Which one you advise for the youngsters like us, or the beginners?
I don't know how young you are, but yeah, I think the literature is it's proven. It's a dead discussion. There's no difference between the two designs. Perhaps there are certain occasions, patelectomy, really severe deformities, where a PS might have a slight advantage. So they both work well. They both work fine. You need to learn how to balance the PCL. I think most guys nowadays also are not using a round on flat design. They're using a round on round or a ultra congruent design. And so I think that helps a lot. So it's really dealer's choice. It's actually a little bit faster. You don't got to cut a box. You don't got to destabilize the condyles in that way. Sometimes you have to tether the PCL a little bit and release it to some degree. But the answer is there's really no difference, and it kind of comes down to what philosophy you believe in, and at least learn one technique extremely well, and you can apply it for 99% of the cases.
Thank you, sir.
Rajshekhar, is Amar got one more talk on complex knees before I do, or I go now?
You have to go now. I think he is.
Okay, that's fine.
So
just allow me to upload. Yeah. Can you see my presentation now?
Yes, sir.
Okay, great. Okay. My brief is you've given me about 6 to 8 minutes. I should finish well within that.
Take your time, sir. Nothing like that.
Yeah. Firstly, thank you, Rajshekhar, Mallikarjun, and Roshan to invite me to be part of this excellent symposium. It was a real pleasure to hear both Parag and Dr. Amar speak. My brief is to talk about difficult scenario in complex knees. However complex the situation is, the principle remains the same. You want to give a stable, mobile, and pain-free joint with good longevity. That's your ultimate aim. And how do we negotiate through difficulties and try and reach this goal is something we need to work it out. When we talk about how this can be achieved, correct alignment is important, like Parag said. Preserving bone stock and replacing the bone defects will go a long way in case you need to revise or the survivability will get better. And it's all about soft tissue balancing. We know that. Maintain the joint line, get it right so that you don't have those patellofemoral problems, and use just the right amount of constraint. This is an art. You need to know when to stop and when to go for more constraint. I don't think you can keep saying, for the sake of safety, I'll use more constraint at the cost of compromising on the longevity. So use the right amount of constraint is a judgment call one needs to take as an orthoplasty surgeon. When we call about complex primary knees, there are many situations. You had situations where many previous operations are done, may it be for trauma, may it be for infection or whatever else. Severe coronal deformities could be there. It could be because of varus, valgus, and some amount of osteotomies which could have disfigured the anatomy around the joint. Stiff knees, not a very uncommon problem at all. Like I said, osteotomies can alter the anatomy and completely take you off the orientation one needs to be careful about. One can never miss extra-articular deformities. If you miss, you will really compromise on the overall alignment. And that's something which we need to take care of, whether it's correctable intra-articularly or you need to do something more. I'll quickly take you through a few examples to illustrate some of the complex knees one comes across. This is something extremely common in our country. Somebody who had a fracture and that's operated fixed with implants, and then they go on to have arthritis. This gentleman had a valgus knee with arthritis, mainly on the lateral compartment. As you can see, there are implants there. Two important principles whenever you have an implant inside the bones where you're going to be operating and doing an arthroplasty. First thing is you need to be sure that there's no infection lurking around. So your biochemical parameters and, if necessary, aspiration of that area, make sure you're not having any infection lurking around, especially if you're doing it as one stage. Of course, if you find anything on the table, you need to just do it as a two-stage and make sure there's no infection, because compromising on that could cost a lot of hardship, both for the surgeon and the patient. And these kind of patients invariably have scars, invariably have incisions of different kind. One of the lessons here you'd like to know is when there are multiple scars, how to go about it. There's certain principles one needs to adhere to when you're doing these operations. If you have to make 2 incisions to remove the implants and do your knee orthoplasty, the incisions have to be certain amount of space apart. This is how you look at it, and it has to be 1:2 ratio. And if you have the 2 incisions this apart, then the chance of having any necrosis or tissue and skin problems become less. And this is a principle you learn from the plastic surgery techniques, where you need to maintain some distance before you make multiple incisions, or you try and go in a single incision, remove it. Sometimes it's difficult and you need to take the help to maintain this nice soft tissue envelope, take the help of the plastic surgeons. This gentleman, 10 weeks post-operatively, you can see both the scars have healed well and there is no problem with the skin. So that's the principle you need to follow when you're doing these things. Let's take another situation. This gentleman had osteotomy when he was young, and as you can see, there are implants inside, and he's gone on to develop severe osteoarthritis. And obviously, the choice of treatment here is a knee arthroplasty. When you're doing a knee replacement, you ruled out infection, and then you plan to do it in one stage, which is more often than not we do it in our country, cost constraints, and also as long as you follow the principles, you feel comfortable doing this. What you notice in this particular x-ray is the tuberosity area looks a little dicey, even though he has good muscle power, able to straight leg raise and everything else, and you do expect some altered anatomy inside. When we went inside, we found the medullary canal was not really in connection with how the tibial platform was. And there was a lot of malrotation, and you need to be careful to get your alignment right when you're doing something like this. Surprise, surprise, when we went in, we also found that the tibial tubercle area, or the anterior part, was almost free floating in spite of the patellar tendon being in place. The front of the tibial platform was almost like a loose piece. We went on to fix this loose piece, put it in place after we had stemmed it. We put this whole thing in place and had to use multiple screws. When you do this in an already operated knee in the past, you know you can get into trouble with the soft tissue. That was how the wound looked initially, and then went on to have a discharging sinus. And when you see a situation like this, obviously this is worrying. And in this particular case, we went in and removed the screws. The fracture or the fragment had already started to integrate. At the end of it, we had a reasonably good result. One of the lessons which I keep saying when we are operating on this complex knees is to be sure you had a good conversation with the patient, the relatives, and explain to them that the chances of having problems could be much higher than a conventional classic primary knee orthoplasty, where you can more or less confidently say it will last long enough for them to have a very productive and qualitative life. The chance of complications are minimal, but in these instances, the complication chances definitely go up, and one needs to have a conversation with everyone concerned, and explaining this is one of the important things. This is a lady who had kind of had a spontaneous rupture of the patellar tendon on the left side, as you can see, and she had severe pain on both sides, and she was keen to have orthoplasty done. And when we saw her, in fact, this was a little strange because these X-rays were proper and there was no patellar tendon rupture when I first saw her. And this was when she came back a second time around with the old X-rays. We admitted her saying that we'll go ahead and do the knee replacement. When we did the fresh X-rays, we found this was the scene, and she was managing to walk with that deficient extensor mechanism. And the way we went about doing this is the right side, we went on to do a classic knee replacement surgery, whereas on the left side in the same sitting, opened up to see if we can reconstruct the patellar tendon. What we did was we used the fasciolata, and there was a very, very thinned out patellar tendon which was elongated. We tried to put it all together, reconstructed the entire area with the fasciolata, and when we did that, we put it all together, and it looked good at that moment of time, but we deferred a knee replacement surgery for this lady. And to protect our whole repair, as you can see in this, we used the classical wire to not to allow her to bend the knee too much and give enough sufficient splintage or restriction for the patellar reconstruction to be in place. Whereas the right side, we went on to have a knee replacement. In the second stage, went back in only to find that this extensor mechanism had continuity, but it was pretty fibrotic, and even then a little lax. Not very comfortable leaving her like that. We went on to do further augmentation of the patellar tendon using the hamstrings. And when we use the hamstrings, put it all together and made a good solid extensor mechanism, went on to do a knee replacement as a second stage. And this seemed to have given us the adequate amount of comfort, and we went on to give her a whole lot of physiotherapy, and she ended up having a good result. This is not necessarily the rule every time, and there are other methods of reconstructing the patellar tendon. We know that we can use allografts and so many other ways of doing it, but this was a situation where we could we could reconstruct it using the native tissue quite adequately. That was a follow-up X-ray of hers. Even though the patella looks a little higher on the left side, she is doing pretty well and has got minimal extensor lag and comfortably gets around. This is a very interesting situation as well. This gentleman came to see me. You can see he was 67, and he had trauma, multiple surgeries. Look at his leg. It was dark, dusky. His vascular insufficiency was there, but he was really crippled, and he lived in Australia. He had come back and he wanted to have a better quality of life, and he was very keen to have the surgery done. We said, fine, and then he came back. When I saw him, this is how the X-ray looked: atherosclerotic artery at the back, and the knee absolutely stiff. And it was subluxed and stiff and not able to move much. And we had listed him for surgery, and he came back after a few months. And when he came back after a few months, that's the picture what we saw in a fresh X-ray. That stiff knee had really put stress somewhere else, and there was a supracondylar fracture. And this kind of a situation quickly warrants you to think otherwise from a normal regular knee replacement surgery. And you're so stiff, and he had a big compromise in the vascularity distally. Obviously, we checked all that and did it without a tourniquet, but didn't do a simple knee replacement. Went on to put a hinged knee, because we had only one chance to get this, and we didn't want to take a chance with this guy, and all he wanted is reasonable mobility at that age. And this is one of the rare indications when you use a hinge knee in a primary situation. And this was a very satisfying result, I should say. This is yet another patient, not able to walk and stand since 2 years. This is a typical, slightly obese lady, and she was not able to walk. It was interesting. She was diagnosed with a tubercular spine, and she had a psoas abscess, paraparesis. She was treated elsewhere, and she practically was in bed, and she recovered post-surgical spinal decompression, but it took all of 2 years for her to recover, and she had not walked. And surprise, surprise, with all those muscle weaknesses, she had developed a knee dislocation. Classically, you get a triple displacement in tuberculosis of the knee, but this was a spinal tuberculosis which had led to paraparesis, and she had developed a dislocated knee. The family and herself, when they got back all the muscle power, were so keen to have something done. This is not for faint hearts. As you can see, the knee is completely dislocated, and now her muscle power is back, and she was very keen to do it. And she wanted to have something done. We thought about it long and hard, dissuaded her from going for anything dramatic. We said, we can fuse the knee, we can put her back into place, but she wouldn't agree. And with all the explanation and everything else, the only way we thought we can get around this problem was to put her on a frame and distract it. There's no way I thought we can get this on the operating table back into place, whatever we use. Even if we were going to use a hinge, we never felt that we could get this back. We used a frame, then started distracting it gradually, watching her vascularity and everything else. Finally, we could get it up reasonably to the length. And when we got this reasonably to length, we had the pin tracks checked out. We did take away the entire frame and put her on a calcaneal pin traction for a reasonable length of time, make sure that we don't have any pin tracks to deal with, and finally went in and had the most challenging surgical procedure when we had to get this knee together and do a hinge knee. As you can see, the patella is all over the place, and we had to resect a fairly significant amount of the femur to get this whole thing into place. As I said, this was a little too heroic. I wouldn't recommend it every time a situation arises like this to do it, but this was really pushed to the wall. And I should say, this lady was happy at the end of it, but her quadriceps mechanism was not great. She manages even now to move around with a knee brace, and that's the only quality of life we could give it to her, and she is reasonably happy with that. Take-home message is, first attempt is the best attempt as we know it. And one needs to think through the entire procedure, what you're going to do, rehearse it in your mind, be prepared to be surprised. Even with all the rehearsal in the mind, you could easily be surprised. And like Dr. Amar was saying, one needs to have the entire armamentarium. Even though if it's a primary, if it is a complex primary, we need to have the backup. Sometimes we need revision stuff as primary, and we need to have that. And again, to emphasize, we cannot expect the similar kind of results what we get in the primaries, and one needs to educate the patient for possible complications and face them head on and see what's the best we can do to achieve that stable, mobile, pain-free, and a joint which lasts for a long time. Thank you again.
Yeah, thank you very much, sir. It is a really most challenging cases. You made it very easy, but certain things like after doing Elizaro, how many days you waited to get that infection?
Well, there was no infection. Pin tracks were reasonably clean. The parameters were okay, but we are all paranoid about these pins, and Elizaro is something not an orthoplasty surgeon is very comfortable with. We put her in traction and waited for 2 weeks. We had planned to wait for 3 weeks. The patient was running out from all sides, and then we went on to do this. Lucky to get away, but like I said, just because it's presented here does not mean that's a very good option and should not be taken lightly or practiced out of context. One needs to really be very careful of a heroic surgery like this, because vascular compromise could be a big issue, infection could be a big issue, and there are many challenges, and that needs to be taken in that perspective. Yeah.
One of the stiff knee, you have that distal vascularity is a concern, that that from Australian guy came.
Yes.
Post-operative, did you notice anything in that case?
You don't know. He was basically wanting a pain-free mobile knee, and he lived on his own, and he wanted to be comfortable. And vascular compromise didn't get worse after that, and we could bypass the fracture site and put in of course, a hinged knee was the best option, because I could get reasonable mobility, releasing all the soft tissues. It's a pretty nastily stiff knee with a lot of soft tissue, multiple surgeries done in the past. So I really didn't want to take a chance with anything less than releasing all the tissues around, get some good mobility. As far as vascularity is concerned, it stayed status quo.
Dr. Parag, sir, anything to add?
I do.
Amar wants to say something.
Yeah, I think in the most extreme cases that you're describing, where the vascular condition is such that you are uncertain of what is going to happen.
Yeah.
That's where you need to have a vascular surgeon available.
Yeah.
And sometimes they can pre-stent the popliteal artery, and just have it so you know what's going to happen. There's going to be circulation, but whether he keeps the stent or not after that can be up to the vascular surgeon. But these are the wonderful cases where you really need to have the input from multiple surgeons. Plastic surgery for wound closure, vascular surgery to protect the vessels, the orthopedic surgeon, sometimes the trauma surgeon to help you out with the Elizaroffs and things. So there are a variety of times where you can have a team approach to these things. You don't have to be expert in every aspect of this surgery, but if you are, that's great. And then if you are not, get another expert to help you.
great suggestions, and I really think it's teamwork and absolutely zero egos in this. And you need help, and the patient is the most important part of our lives and practice. I really think it's a combined wisdom of everything around to give the best to the patient is the philosophy, and we all need to work together to give what is best for the patient, irrespective of what the equation is. I completely agree with that. Yeah.
Thank you, sir. Now we'll go to Dr. Rajshekhar KT. He's our senior most orthoplasty surgeon from Columbia Hospital, and he's going to talk on FFD. You unmuted.
Can you hear me?
Yes, sir.
You can hear me. Good. Okay. So yeah, I mean, the internet was so slow, nothing was working. Couldn't hear the previous lectures, but I heard the last part of Sharan's lecture was super duper. And I think I'll start off with the lecture. Fixed flexion deformities can be because of bony causes. When you have large osteophytes anteriorly, they work as a bone block, preventing full extension. You can have large osteophytes posteriorly, and they tent up the posterior capsule, preventing extension. And apart from that, you can have actual contractures of the posterior capsule, hamstring tendons. And if the deformity is very severe, the collateral ligaments are also contracted. And this fixed flexion deformity is very, very disabling. The energy costs during ambulation is tremendous. If you've got bilateral fixed flexion deformity of about 30 degrees, the quads have to work for 50% extra. When I was a first-year medical student in Banaras Hindu University, the seniors used to make us murga. This is not actually a murga position, but I can tell you it's so tiring, so tiring. And if you can correct a flexion deformity, the patients are so happy, they're over the moon, they're so grateful, and you get loads and loads of blessings. Now, in a chronic fixed flexion deformity, the extensor mechanism is attenuated. The quadriceps muscle is wasted, the anterior capsule and the ligament patella, they're a little stretched. And so when you sort of operate on these cases, you're left with a major extensor lag. And for that reason, you need to continue post-operative splintage for a long time. Now, FFDs trouble us right from the very beginning. If you're doing a conventional AP X-ray, the image is magnified, and so it is difficult templating. And if your X-ray people have not taken the X-rays in correct rotation, again, you are in the soup. Let's say this is a pure flexion deformity. And if the X-rays have been taken with the hip in internal rotation, you tend to think, oh, there is a quantum of valgus. And if the same X-rays are taken in external rotation, then you feel, oh, there is a bit of a varus. Now, in an arthroplasty meeting, hardly anybody talks about serial casting, traction, and stuff like that. But I believe a fair amount in soft tissue release. And I'll be speaking about it a little later. Now, the principle of correction is the same for all deformities. You've got to correct the deformity, but while doing so, you have to achieve equal flexion and extension gaps. Extension gap is the problem in fixed flexion deformity. It's narrower. And to get back the extension gap, you need to release the posterior capsule from the femur, from the back of the tibia, and you have to remove all osteophytes from the back of the femur and tibia. Right? Now, most of us people here would murder the PCL, we kill off the PCL, but there are certain few cases, like Sharon was mentioning the paraparesis patient with posterior subluxation and external rotation. If you've got posterior subluxation, then the PCL actually is a little attenuated, is actually lengthened. If your deformity is very severe, then your collateral ligaments will be contracted. And for that, you need to take the collateral ligaments, release them subperiostally off the lower end of the femur, skeletalize the lower end of the femur. But once you do that, you're moving towards a constrained implant. Now, this is what you do. You need to take off the posterior osteophytes. Once you've done that, take off the posterior capsule. And if it's a very severe deformity, then you need to do an extended release. And with your blunt curve periosteum elevator or Cobb's periosteal elevator, you need to go about 5 to 7 centimeters along the back of the femur subperiosteally and release the medial and lateral heads of the gastrocnemius. And finally, you may need to cut the posterior capsule transversely with an electrocautery. In the beginning, you can use a blunt curve instrument and do this with a sponge. You can gently pry off the posterior capsule of the femur, and hopefully this protects your neurovascular bundle. And finally, you can even take off the posterior capsule by completely subluxating the femur and the tibia. This is not easy on the very, very severely stiff knee. But if the knee is relatively easy, you can do this, and you bend your cautery tip to 90 degrees and take off the posterior capsule from the tibia. In the same position with an osteotome, you can take off the large osteophytes on the tibia if there are any. But finally, when you've done everything with all these acrobatics, if you've not been able to get your extensor gap, then you take off more bone from the distal femur. For every 1 millimeter of distal femoral cut, your deformity is corrected by 4 degrees. But, the more you cut the distal femur, your joint line keeps on getting elevated. And if your joint line gets elevated, there is a relative patella baja, relative patella infera, and then you have patellofemoral problems. Having said that, these days I've become old and lazy. What I do is, if it's a severe deformity, stiff deformity, I take 2 millimeter or 4 millimeter right at the very beginning. But you've got to understand that there is a finite amount of bone that you can take from the distal femur. If you go more than 5 to 8 millimeters, especially in a small knee, definitely you'll go through the origin of the collateral ligaments, and then you'll end up with a constrained implant. The other dreaded complication is a mid-flexion instability. To be very, very careful about that. Finally, you've got to achieve full correction on the table, especially in osteoarthritis. You cannot blame your physio. Rheumatoid joints stretch out. They sort of pardon you if you've left a little bit of deformity behind. Okay, but in case you have to do an MUA, do it at 2 weeks. Or 3 weeks, but don't wait for 6 to 8 weeks or 3 months, You sort of burn your boats by then. The other thing is, you've got to be aware of neurovascular problems. These deformities, severe deformities, have to be done bilaterally in the same sitting. And we do it many times under epidural anesthesia. So therefore, once you finish operating, you tell your anesthetist colleagues that, boss, do not top up the epidural till I have a look at the patient post-operatively. And finally, I have mentioned the quadriceps lag, and you need to do prolonged post-op splinting till the quads lag corrects. This is lady rheumatoid, nearly 90 degrees flexion deformity, wheelchair bound. These are her AP views, and these are the lateral views, very thin osteoporotic bone. And we did the right side, and the left side, we didn't have a femoral stem, so what we did was release the hamstrings on both sides. Okay, and here 3 weeks later, the knees are nice and straight. On the table, both knees are straight. And here, there's the lateral side. If you can see, from the head of the fibula, we made a fairly large incision because initially I used to take off the iliotibial band, I used to do a Z-plasty of the biceps tendon, even take off the lateral head of the gastrocnemius and try and spare the lateral popliteal nerve. But nowadays, I make a smaller incision at the musculotendinous junction and just do a fractional lengthening. So when I opened this knee, I got a shock of my life. That's the articular surface, and it's totally sunken. You probably see it better here. That's the medial condylar articular surface, and that is the shell of the medial condyle. And when I saw this, I had a heart attack. I said, what the bloody hell will I do? After scratching my head for some time, carried on operating, knee came out straight. That's the straight knee, bent knee. Those are the post-op x-rays. And this is the lady walking a month after her second knee. Now this is another lady, sort of again rheumatoid, and she was 59 years old, and she was totally bedridden when she came to me. And all her joints, both her knees, both her hips, had about 40 to 50 degrees of flexion deformity. So the dilemma was, what the hell do we do? If we do one knee after the other, one joint after the other, I'd still be operating on her. So the thing was, the orthopedic dictum is, do the hips first and follow with the knee. But doing bilateral hips, managing the knees with such gross flexion becomes very difficult. You can't mobilize, and nursing becomes difficult. So then what we said, that if everything goes well, we will do everything together. I actually didn't want to do it, but I had a registrar, Dr. Prashant, and Prashant, he's the owner of the specialty hospital, and he said, "Nahi, we will do it, chalo karte hain." So anyway, we first put the patient prone, released both the medial and lateral hamstring muscles, and then turned her to one side, did one hip, turned her to the other side, did the other hip, and then put her supine, and then did both the knees. That's the hip, that's the knee, there's bent. And second post-op day, the patient was walking with a smile on her face, believe it or not. Again, rheumatoid, this lady with rheumatoid. Now, most of these flexion deformities are rheumatoid, and they are much more grosser than osteoarthritic knees, but they are easier to correct than an osteoarthritic knee. Osteoarthritic knee may be a little less deformed, but I find them much more stiff, much more tough to correct. So when he's turning, you can see the flexion deformity, and yeah, there you are. And the neurosurgeons, they were sort of fixing the atlantoaxial subluxation in the prone position. And this is something the youngsters should know. If you've got a rheumatoid, many times you cannot get in a spinal, and you may need to do an intubation. And if you've not looked at a lateral view of your cervical spine, you can have a disaster on the table. You need to do a fiber optic intubation. So here, while they were doing the atlantoaxial, again we did a fractional lengthening of both the knees, and here you can see that I have not killed the PCL. It's a cruciate retaining implant, and 6 weeks after surgery, look at how happy the patient is. It's a really gratifying surgery. Now, I have spoken of conventional method. This is totally unconventional, and Amar will probably will have a heart attack when I talk about this. I'm a CR surgeon, and I gave a slope of 5 to 7 degrees. But in a fixed flexion deformity, when the flexion gap increases, I cut at 90 degrees. But sometimes, when the patient cannot afford a backup of a constrained implant, here we do a reverse slope, okay? And here, if you do a reverse slope, the extensor gap increases, and nothing happens to the flexion gap. We know how to increase the slope. If I move this away from the ankle, the slope increases. And if I move it away from the top part, you start getting a reverse slope. The other thing that I need to tell you, that how to decrease the flexion gap. You need to decrease the flexion gap by always upsizing the femoral component. If you are in between sizes, this is one place, FFD, that you have to always upsize, right? And you can use an offset stem. With an offset stem, you can posteriorize your femoral component. What I do is I use a much cheaper short stubby cemented stem. And this, inside the cement mantle, you can bring down the femoral component posteriorly. And these short stubby cemented stems help. In case you do an MUA, it protects the having a supracondylar fracture, especially if you have made a small, if you've notched the femur. I've spoken about reverse slope. The other thing that I mentioned was the extension gap, the extension lag. So that you can decrease it to a certain extent by, pull up the lateral structures proximally and pull down the vastus medialis and the patellar retinaculum distally and suture it in extension. And to a certain extent, you can tighten your extension. Last, like I said, a bit of a revision, use short cemented stems. In the tibia, it gives you additional fixation. And in the femur, like I said, it may help you to prevent a supracondylar fracture during manipulation, if you need to do a manipulation. And the other thing, in these rheumatoid cases, they're very, very fragile, very fragile. So do not bang the poly on the tibial base plate on the tibia. Do it on the outside. It's like that. So you use a short stubby stem and bang the poly on outside. Okay, otherwise the whole thing may sink inside the tibia. And I think Sharon would remember it. This was taught to me by an OT assistant. Name was Muniraj. And when Sharan left Manipal, he took Muniraj with him. But what I'm trying to tell you, that you learn stuff even from the lowest of lowest. And you have to be humble and benign to sort of listen. And as you know, that yes, everybody teaches you everything. And I think Muniraj taught me how not to get into trouble in these rheumatoid things. I've spoken about extensive mechanism tightening, prolonged splinting, I've told you, again, early MUA. If you have got to do an MUA, early MUA. And if you are left with some 5-7 degrees of fixed flexion deformity, it doesn't matter. Nothing happens to the patient. They walk fairly normal. And always do same sitting bilateral. Okay? Otherwise, the deformity will revert if you've done one. And if for some reason you cannot do both knees at the same sitting, then do it after a couple of days. Don't wait for our standard thing that 2-3 months later we'll do the other one. No, it doesn't work. Yes, it's taking a bit of risk, but then we've got to do it to get the patient up and about. Yeah. And finally, I've mentioned about the neurovascular deficits. Thank you all. Thank you very much. And thank you very much.
Sir, Sharanya, I looks like from my PG days to now, you got even better teacher. So,
and I was so scared. First webinar that I'm doing, and it was not working. So I was supposed to do it from my home, and I thought I'll have a gin and tonic while I went to the hospital for the internet, and then go home and have my gin and tonic.
You're as sweet as ever. And sorry for taking Munraj away from Manipal Hospital. Sir, but generally we are taught that reverse slope is a crime because so how do you explain? I know there are challenging situations when you are trying to balance it. Now, let's say how much of a crime is it? Because
it's terrible. I mean, if the X-rays go to the surgeon across the road, he will say, "Which bloody idiot operated on that?" So it is. But like Amar mentioned, that we no longer do the flat CR thingies.
Okay.
Now we have curved polys, and so it gives you a fair bit of stability.
Yeah.
Okay. And while taking a reverse slope, you don't take a huge slope. You take very little. If you take a huge slope, your posterior, your stem of the tibial will go and strike against the posterior cortex of the tibia.
Yeah.
So you have to be very, very careful. Okay, a bit of templating in it initially does help you. I really don't do much of a templating, but these cases, yes, I would template.
Rajshekhar, you're there? You can take from there.
Yeah, can you hear me, sir?
Yeah, very much.
Yeah. This reverse slope you have been, since how many years you have been doing and how many years you have followed?
No, I have to be honest, not very many. No, because it's not that the flexion deformities come too much. All these are my old cases. You've seen that nearly 10 years follow-up, the cases that I showed. But I am worried doing a reverse slope. But if the patient is someone who will not be able to afford constrained implant, and for Amar, it's so easy to say you've got to keep this backup, you've got to keep that backup. How many times when we ask for a TC3, we don't get the whole set? Forget about a constrained knee, and our services are much poor than in the hospital of special services. There, everything is on the shelf. Ask for anything and you get it. And if you don't like it, you just throw it again and demand for something else. Yes, the managers are coming in and putting brakes on, but everything is there for a bailout procedure.
I did a primary knee and breech care knee hospital 20 years ago, and we called for an 18 or a 10 millimeter insert on the PFC knee, 10 millimeters. The guy's like, "I have 8 and 12." So it was like, "All right, give me the saw." I cut a little more tibia. I know what it's like, but yes, I agree. It's obviously a pleasure to be in a place where we have literally almost every implant on the shelf in the hospital. That's what makes it a special place. I mean, to be fair.
Absolutely. I remember once when I was in England, and the surgeon there was doing the SROM hip for the first time, and it did not have the proper thing. And would you believe it? The medical rep who was there inside the theater rang up, and they flew it in a helicopter from London. So, I mean, that's the amount of thing that you get in the West, which we don't. Things are catching up. We are getting better.
Sometimes we have to get stuff from New Jersey, but that's pretty uncommon.
Thank you, sir. It was a wonderful teaching lesson where in rheumatoid arthritis, in a deformity, even though you don't need for a constrained knee, you can balance the knee well with prior hamstring release, then go for knee replacement. It's a very good lesson and it works well. Thanks you. It is a really a good idea for who are attending, and they can develop these ideas. Next, we'll go to. Yeah.
Thank you, Rajshekhar. You're very, very kind. Thank you. Thank you.
Next, we will go to Dr. Deepak from Orthopaedic Medical College, and he's a private practitioner there and senior Arthroplasty Surgeon from Mangalore. He's going to speak on neuropathic joints. Dr. Deepak.
Yeah, good evening, Dr. Rajshekhar. Are you able to see my slides?
Yes, sir.
Yeah.
No, not yet.
A very good evening to one and all, and greetings on the occasion of Bone and Joint Week from the city of Mangalore. At the outset, I'd like to thank Dr. Mallikarjun Swamy, President KOA, and Dr. Roshan, Secretary, for inviting me for this KOA webinar series 4 on complex. And I decided to stick my neck out in the diabetic neuropathic knee. As we all know that there is an increasing incidence of early onset diabetes and a changing lifestyle. So we are bound to see more and more diabetic-induced neuropathic joints. And it's been quite definitely underreported, under-researched, very few papers to fall back on, and it's always a dilemma to the surgeons. Neuropathic joints basically is an absence of nociception and undetected repeated microtraumas and microfractures which lead to rapidly progressive degenerative disease causing severe deformity as well as joint dysfunction.
Doctor, slides are not visible, I think. Slides are not visible.
We cannot see the slides, sir.
You cannot see the slides?
No,
Please.
Oh, okay. I'm so sorry, but I thought the slides was visible. I think somebody has to help me on this then. I don't know, but playing here. Rajshekhar, can you see the slides?
No, sir. It's not there.
Sorry?
Can you share it again? Open your presentation.
My presentation is open and I'm on an iPad. And day before yesterday, I think it was working. Share. Okay. 1 second, please. Start that post. Okay. Can you see it now?
Yeah.
Yes.
Yeah.
Yes, we can see, sir.
So, I'll be sticking out my neck on diabetic neuropathic knee with an increasing incidence of early onset diabetes and changing lifestyle. Definitely, we are going to see more and more of these diabetic induced neuropathic joints. It's been underreported, under-researched, very few papers to fall back on, and it's always a dilemma to the surgeon. And it's definitely been a word of caution to our younger colleagues. Neuropathic joints is basically an absence of nociception, undetected repeated microtraumas and fractures leading to rapidly progressive degenerative disease. Causes severe deformity as well as dysfunction, and classically most of the patients come with a warm, swollen joints with repeated histories of the same thing. Whether to do a total knee replacement in the neuropathic joint is probably an absolute contraindication for most surgeons. Some would definitely dispute it, but I guess it's experience and judicious planning which needs to be done in every case. I decided to review all our neuropathic cases in our center from 2014, and we found out 6 cases with diabetic neuropathic joint, which are all assessed by the neurologist as well as electrophysiological studies were done. All patients were given adequate conservative management, and only when they didn't respond and they had asked for it, we went in for doing total knee. We did a rotating hinge in 4 and a constraint in 2. We had really good results in 5, but then things can go wrong too. And I'd like to talk about this one case which I did in 2015. And you always know that the clinical picture varies from patient to patient. You would have skin conditions which are not really good to somewhere which is really okay. And it needs to be a thorough clinical examination. We need to look for infective focus, and like Dr. Sharan said, the vascular and the neurological status, and to assess the need for laxities. X-rays definitely would give us pretty good pictures of the defects as well as the laxities. and to plan what sort of a surgery we need to do, whether it needs to do a constrained hinge with allografts or probably just a hinged knee. I'd like to talk about this 56-year-old lady. There's a brief history. She was a known diabetic since 15 years, and she complained of pain, instability, and deformity of the left knee while walking since 3 years. She was more concerned about the instability and occasional swelling, and she had a history of fall thrice in the last 6 months prior to admission. Treated at a local hospital by way of splintage and analgesics, there was no history of fever, constitutional symptoms. Her diabetic status was under very good control, and she wanted a definitive treatment. She had been to multiple surgeons and there were multiple options, but she was very adamant. She wanted a stable and a mobile knee to be given. This is a clinical picture, and I'll put up this video, and yeah, sorry for the poor quality of the video. You can see the patient as she's walking. You can see the lateral thrust on the knee, and the way she's walking, she's got a bilateral foot drop also on both the sides. But she was very much adamant. She said, nothing doing, only a mobile knee is what I need. She refused anything else to go. Clinically, valgus stress test was positive, posterior stag noted. She had a relative painful range of movement from 0 to 110 and a hyperextension of 10 degrees. Synovial thickening was noted, counts were normal, and diabetic status was under very good control. Bilateral foot drop since about 2 years. I definitely did a Doppler study on both the lower limbs, which showed a good flow, but atherosclerotic changes. MRI was not very significant, and I did a nasal and throat swab, which did not reveal any growth. This is X-ray of the patient, and I think we can see on the AP view, there's a huge defect on the tibials condyle, medial tibial condyle. On the lateral view, you can see the luxation of the femur back with the heel fracture of the fibula. So a diagnosis of a diabetic neuropathic knee was made, which was confirmed by neurophysiological studies and also by the neurologist opinion. We again counseled the patient. Did she really want to go? And every option was discussed in detail. She stuck to her guns, whether to operate arthrodesis or not to operate. I did a rotating hinge onto her. She did quite well. Post-operative, she was pretty happy. She was walking. Bilateral foot drop is still there, but she was really happy. Following that, she came once or twice, and she was asymptomatic till Feb 2020. She had a trivial fall and injury to the left foot, seen by a local doctor who put her on a cast, noticed foul smell after 3 weeks. On removal of the cast, there was a purulent discharge on the foot, and she also noticed warmth on the operated knee. The abscess in the foot was treated with antibiotics and drainage. Due to COVID-19, she could not come to Bangalore, and she presented to me in the month of June, second week, with that swollen left knee. The total counts were elevated and neutrophils were elevated. ESR was 53, everything else was normal. And this is how she presented. As you can see, the knee is boggy, definitely all signs of infection. Radiologically, the stems reasonably look quite okay, but there's osteolysis under the tibial plate. And I was a bit worried about this, and I discussed all options with this patient as to what best can be done. She was pretty happy with the knee for 4 years. So she said, like, I don't care what, but you need to save this knee. We did a 4-quadrant aspiration. The fluid was sent for culture, which showed no growth, probably because of the high amount of antibiotics she had taken locally. And what next to do, the treatment options. She refused any sort of treatment, so I went ahead and did an arthrotomy, debridema, put stimulan, and we gave antibiotic irrigation VAC therapy for the next 2 weeks. And on August 1st, last week, the knee is quiescent. The counts are normal. There's no growth from the local swab, but how long, we don't know. Take-home message is that we had to look back through all our articles, and there's not much to fall back on the articles. If you see knee arthroplasties, most of the articles which came out from South Korea, some articles regarding the use of constrained knees, as well as the use of bone grafts, as well as the survivorship of all the stabilized knees. But this one particular article by Jawad Parvezi et al. In 2003 was an eye-opener for me. Of the 40 knees which he did in 29 patients with an average follow-up of 7.9 years, in all these 40 knees, he had 6 reoperations for aseptic loosening, 1 periprosthetic fracture in the femur, 1 had a deep wound infection for which he did a 2-stage arthroplasty, and there were intraoperative complications which include MCL avulsions, patellar tendon ruptures, tibial tuberosity avulsions, instability, DVT, as well as hematoma. Treatment for Charcot's arthroplasty still remains controversial. Recent studies have shown satisfactory results with knee replacement, whether using a condylar or a rotating hinge, and the use of allografts. We need to take into account that ligament instability also necessitates the use of long stem components as well as hinged knee. During surgery, we need to look for bone loss intraoperatively, the poor quality of bone, ligament laxity and infection, and late complications including periprosthetic fracture, aseptic loosening, instability and infections. We need to time the surgery well, plan the technique and prosthetic selection, whether you want to use a rotating hinge or a constraint. Anticipate intraoperatively that you're going to need to use bone grafts. There could be ruptures of the collateral tendons as well as the patellar tendon ruptures. And if this infection, obviously it's going to be a surgeon's call whether to do a 2-stage, abandon the procedure, or go in for arthrodesis. TKA in diabetic neuropathy is not an absolute contraindication, but I feel that careful clinical examination, especially in local, regional infections, the skin condition and the progressive disorders should be taken into account. Dissuade the patient and explain the complications. Regular follow-up is a must with each of these patients, and you need to look at them very clearly. The role of bisphosphonates, well, it's still debatable. And like Dr. Amar said, a surgeon should be bold in all sure things, but cautious in all these unsure things. I still feel that surgery should be done only when conservative modalities have failed. Thank you.
Thank you, Deepak. Is a wonderful, it's an eye opener for the hinge joints, especially in case of a neuropathic joint. So I think hinge is not the only answer or the final answer. Again, we need to be prepared for the revisions. What's your opinion on Dr. Sharan Patel, sir, and Dr. Ramar?
Yeah, I think definitely it is not as safe and as sound and as sure like doing anything else. And these the chance of complications are much higher than otherwise. I also feel this hyperextension. We have neuropathic joint and there's a tendency for hyperextension. Every hinge joint is not suitable for that. And especially you're talking about a link kind of a hinge knee, that's got high failure rate whenever there is hyperextension possibility, whereas other hinges are more suitable. The hinge where it is placed and how the mechanism works, that needs to be considered when you're putting in a hinge, which hinge to choose, especially when there's hyperextension possibility in neuropathic joints.
Absolutely. But one thing, Dr. Sharan, in all these cases, wherever you're using the stem and all that, usually the failure rates occur around the stem and bone interface at a later date. And if you go back to all the papers showed that there's a good number of osteolysis which are seen at about 4 to 5 years' time, and which I feel is probably quite early in a neuropathic joint. I mean, almost all the series shows that there is early osteolysis around that area.
Yeah. No, Deepak, one of the things what I really believe is when you're doing a neuropathic joint is significant amount of destruction in the joint sometimes. But if you do not get a reasonable, good, let's say, femoral component, and with your prosthesis, you don't get some amount of bone to keep it rotationally stable at the condyle level, the loosening is very common in the stem bone interface. And when you're doing a cemented stem, if you're doing a cemented stem, it's very important to do it like a hip. You need to put a cement stopper and then use a cement gun and do it completely like how you're doing a cemented hip to get the best possible purchase in the bone. I think that's a very important thing to do. Even then, if you don't have a good enough condyle and if it starts rotating at that level, it's likely to loosen up, because as we know, there is it's only a grout, the cement, so there is bound to be some amount of movement. You don't get good rotational stability at the condyle level. Dr. Amar, what are your views?
There, unmuted. I agree. Listen, when I have complex cases now, I use less and less cement. Right. I believe in cementless fixation. I believe in sleeves. I just don't think cement can handle the forces of a hinged knee. Can it handle it for a few years? Of course. And if that's all you need, then and that's all you have, it's probably a reasonable alternative. But at the end of the day, non-cemented fixation is superior, in my opinion, longer lasting, and even in the worst case scenario where you get an infection, if I have something in that's non-cemented, it gets infected, I can take it out right away. If you cement a stem up and down the femur and the tibia, that's a long day in the OR trying to get that out.
I agree. There's something interesting. I don't know if you guys are aware that this is very popular in Australia. One chap called Munjed told us a few years ago, and he's practicing it heavily. It is an amputee. He's got a prosthesis, and they've been putting in stems into the intramedullary. Let's say he's a below knee amputee, and he puts a stem into the intramedullary, uncemented stem intramedullary, and there's a silicone interface to which there's a little metal jetting out, and he puts the prosthesis on top of it. And these guys walk on the beach, and unbelievable amount of strain is produced on these uncemented fixations, and he has got very good results. And there are a few people who are doing this very effective. They feel it's part of them, that prosthesis, and they walk on it comfortably. So obviously, uncemented, which is osteointegrating, has got far larger capacity to withstand the torque and the pressures what one can put on them. Yeah, no question. Yeah.
But
if you look at what's going on in the hip right now around the world, probably 90% of the world now is doing uncemented hip replacement. Yep. Cement is, for fractures, some very old and osteoporotic conditions, but 95% are all non-cemented in the hip. It's just a matter of time, in my opinion, that same transition occurs in the knee. You just have to get there, right? The knee is about 10 years behind the hip.
Right.
Problem is in the neuropathic joint, the quality of bone is not that great to get the fixation of uncemented. A lot of shear stress will be there on the femoral component. The chance of loosening either way is a questionable. Dr. Amar?
I didn't understand the question.
In neuropathic joint, the quality of bone is not that great. So the purchase of the bone with uncemented totally implant is really how you should be able to get that purchase.
I would argue that in neuropathic bone, the problem is not the bone. The problem is the stability with the ligaments in the long run. So that using a constrained knee or a hinged knee is a better option. But initial fixation with the bone, that's not the challenge. It's a long-term stability of that knee and their ligaments.
Okay. Dr. Chandrapodi,
joint.
you're
Unmute, please.
In a neuropathic joint, once you have done a joint and if it fails, will you try to revise it, or you will end the surgery, or you will remove the implant and go for any other procedure? Hello?
Can you speak louder?
No. See, in a neuropathic joint, once you have done a joint replacement, and if it goes for failure, can it be revised, or should we go in for orthodontist or excision arthroplasty or something like that?
You see, that's the problem. The problem is, if you do a primary neuropathic joint, it can look very stable on the table. And you're like, oh, this is great. I did a good job. Everything, I'm happy. But then in 3 years, it starts to go like that, right? So you need to anticipate that. So first you need to diagnose it, right? If you diagnose this neuropathic joint, anticipate that and put in a more constrained knee initially, even though it doesn't need it initially, but it will need it in 3 to 5 years when the ligaments start to stretch out.
Okay.
I think Rajshekhar, some question box, something is there from Deepak Shivana has got something to say.
You're able to see only 5 questions here. Anything you are seeing, you can ask them. Here, I'm not able to see anything. Question.
If Deepak Shivana is asking a question, it has to be a hard one.
I know he's going to be after my blood.
You know?
Can you move to Dr. Sharath? Like Sharath is a professor in Ramayam College, an orthoplasty surgeon. Is going to speak on fused knees. Dr. Sharath.
Good evening, Dr. Rajshekhar, and good evening, Mallikarjun sir, and Chandramani sir, and Karnataka Orthopaedic Association for having me here. So the topic given to me is fused knee. So it is a rare entity. Usually, some movement will be possible, and initially there will be flexion deformity, and after opening, we will get some movement. And only very rare circumstances we will have the completely fused. Or if we are planning to go for fused knee, completely arthrodesed knee, it is usually juvenile rheumatoid arthritis or rheumatoid arthritis in some adults, which is of long-standing duration, or psoriatic arthritis, or post-traumatic arthritis with multiple surgical procedures. There is no movement possible. This is a case where I'm presenting here with the fused knee of a 62-year-old female. You can see there is bone formation between the patella and suprapatellar area, patella and the distal femur, and there is a joint line visible in the X-ray, but it was not movement. There is no movement possible during surgery. So it's better to obtain long X-rays to check if there is any other involvement of hip or ankle joint. As you can see, so there is no movement possible in the knee. So the plan, whenever we are dealing with a fused knee, we have to keep posterior stabilized knee and keep a semi-constrained, and hinge also possible depending on the case. In situ proximal tibial osteotomy if there is no movement at all, because it's a freehand proximal tibial osteotomy. We cannot use intramedullary or extramedullary jigs, and usage of rectus or quadriceps snip. Better to do this rather than doing a tibial tuberosity osteotomy, and removal of the remnant of tibia adherent to the distal femur if there is completely fusion, and locate the intercondylar notch of the femur after tibial cut is done. And if there is a flexion, fusion in flexion, it's better to take maximum possible distal femur resection, and do not undersize the femoral component if it is in flexion, because most of the times it is a flexion gap which is more than the extension gap. and posterior capsular releases of the femur and tibia, and release of the muscles adherent to the anterior femur, and use of stem extension to the femur and tibia, as severe osteoporosis will be there, and checking the stem in the C-arm. So choose the implant which has possibility to use femoral stems in primary implant, as it was discussed, and avoid eversion of the patella, and subluxation is to be done. And when tibial resection is performed, it is advisable to apply no slope to the cut, because we will be using stem, and the stem may hit the anterior cortex. If there is any movement possible after patellar eversion, first perform distal femur resection. If there is no movement possible, then freehand distal femur cut. So the measure to gain flexion, so maximal trochlear resection, and keep the patellar as thin as possible, so that these two measures enhance the flexion by increasing the quadriceps excursion. So as I was telling, the proximal release, VY-plasty or quadriceps snip or tubercle osteotomy. So most of the times we can use this insal oblique quadriceps snip at the apex of the tendon, a 45-degree oblique cut. And prophylactic pin at the tibial tuberosity, where the patellar tendon, to avoid the avulsion of the patellar tendon. So with that, I will quickly show the freehand distal femur cut. See, there is no movement at the possible. So, distal femur, anterior aspect of the distal femur, release of the muscles adherent to the anterior femur with the osteotomes, and release of the completely adherent quadriceps. And with osteotome, patella is the bone is removed from the distal femur, which is attached to the patella is attached. So patella is everted, and patella is subluxated. Avoid eversion of the patella, and release the synovium adherent to the patella, inferior aspect of the patella, and the distal femur. And there is no movement, possible. So with the freehand proximal tibial resection, guided by the X-ray, we should not give the slope here. This is a freehand cut, the minimum proximal tibial resection. When there is no movement possible, it is better to cut proximal tibia than distal femur, because we don't know the valgus angle. Here proximal tibia is resection is done with the freehand. So how much medially, and this is a quadriceps snip. Before we flex the knee, the quadriceps snip is being done. And then the flexion is done. Now the flexion happens at the area of the osteotomy, and there is some tibia remnant is adherent to the distal femur. So we need to remove that to locate the intramedullary intercondylar notch of the distal femur, and we can cut the distal femur maximum. And still after that, we have, in this case, there was about 40 degrees of flexion deformity. So as it was described, posterior capsular releases in the femur and the tibia. And most of these cases will have more flexion gap than extension gap. So we should not cut more proximal tibia. the maximum possible distal femur has been resected, and keep the semi-constraint in case if you feel flexion and extension gap is not balanced. And this is a trial. And since most of these patients will have osteoporosis, better to use the stem, short cemented stem of the femoral and tibial side. And whenever we do the stem trial, is always better to check the C-arm images. And I would like to add that in C-arm, we can see that the overhanging implant posteriorly seen. This is because of excessive distal femur resection we have made, and we have used the little larger instead of undersizing the femoral component. It is between. If it is between the sizes, we use the higher size possible to get the flexion space more and extension space less. So this is the postoperative X-ray, and this is the correction of the deformity. And whenever we see surgical orthodesis, its results of TKR are not so good due to improper or abnormal extensor mechanism. So if there is sound union and patella has been sacrificed, it is better to not plan knee replacement. If at all is planned, then keep the hinge as an option. So thank you for your kind attention.
The tendon avulsion and how to get an exposure is very important, and cutting the tibia, adding the value. And I think Dr. Shan Patel sir can add some more information to that. Anything, Dr. Amar?
Yeah, I think it's one of the more challenging aspects of doing knee replacement on a fused knee. Like Sharath was saying, if it is surgically fused, it becomes even more difficult. Yes, planning is very important, and I think Sharath has made most of the points very effectively. One of the important things is to locate where exactly you want to do the osteotomy is important. Fibular head is a very good marker. And patella sometimes is a reasonably good marker where your knee has to be resected. I think it's a good idea to do a trapezoidal resection so that you make two cuts in a trapezoidal fashion to start with, so that you go in safely, and you need to be really worried about protecting the structures right at the back of the knee, because the knee in extension means all the neurovascular bundle is very close there, and one needs to be careful. Take your time to do it. And this is one surgery where you cannot go in without your hinge prosthesis available, because it's not always this particular surgery was what Sharath showed us. There's a nice soft tissue balancing, which is not always possible to obtain. When you're doing your cuts, you generally tend to lose the posterior condyles of the femur, and the flexion extension gaps can go haywire, and one needs to be really prepared to put in a hinge, and this operation has to be done very judiciously, and the patient has to be picked very carefully, because fused knee, if they got used to it, it's a very comfortable option, and in the promise of giving them fantastic something new, I don't think we should worsen the patient's lifestyle, because the complications can be quite traumatic. That's what I would like to say.
You know, I agree with everything you said. I would only differ in that level of philosophy, where I think you should approach the conversion of a fused knee with 100% determination to put in a hinged knee. Yes, we saw some cases like that, and that's, but the reality is the exposure is difficult. Cutting everything is difficult. So you cut everything as if you're putting in a hinged knee. You can make a difficult operation easier because you know in your mind, this is where I'm going to end up. So that would be my philosophical approach. I would never even consider putting anything less than a hinge.
Okay. Dr. Deepak, anything to add to that?
Oh, no, nothing. That's okay.
Dr. Modi, sir? Nothing. Okay.
And just one more thing is I'm sure Sharath would agree with me that
Yes,
the rehab is definitely challenging.
Yes, sir.
Get your extensor strength back.
Yes, sir.
And don't promise them the moon and don't tell them they'll get great range of movements.
Yes,
Everything is guarded. Everything is a little challenging. But like Amar said, hinge knee is a very comfortable thing to do because you go with that much more freedom, not trying to be over careful. I mean, I've heard a lot of people say that they get away without a hinge knee. In my book, it's 100% of the time I have done hinge knee whenever I've gone in and done it. But because a lot of people say we can do it, I would give them that. But it definitely, a hinge knee gives you that much more comfort in terms of, because your range of movements get better when you are taking away all the soft tissue. The only thing you really need to watch out for is a good quadriceps mechanism at the end of it, and that will really help you.
Yes, sir. Yes, sir. Yes, absolutely true. Maybe some of such cases we can go away without hinge. Otherwise, we have to keep the hinge always as a backup, sir.
Perfect. Thank you.
Thank you, sir.
Thank you, Sharath.
Thank you, sir.
Really a great lecture. So, I think any Dr. Chandra, anything to add to you from?
What time is it in India right now?
It's 7:10.
7:11, 2 hours.
7 p.m.
7 p.m.
It's 9:40 here in the morning.
Oh.
Right.
You guys are gonna go get gin and tonics, and I'm gonna have to get.
End the talks and thank you for panelists and Dr. Amar and thank you Karnataka Orthopaedic Association, Dr. Mallikarjun Swamy, President, and Chair, Dr. Secretary, Dr. Roshan, and even our managing team, the Mr. KOA managing team, the from the company.
Microlab Sheffield is there.
Microlab Sheffield and other your all postgraduate which are helpful to organize this wonderfully. It was a really a great lesson to learn so many things from Dr. Sharan Patil, Dr. Amar Ranawat, his whole from Dr. Chitranjan Ranawat, his whole life lessons. They are very key points, and even Dr. Sharath showed a very good presentation of refuse to operate, and Dr. Deepak Rai showed us a very difficult cases with us, and how to use the hinge joints in case of neuropathic. Thank you, Rizal. Thank you very much, and Dr.
Thank you.
To Dr.
So let me put in one little plug. So in January, we've normally done our ROC meeting. We're not going to come this year. There's just too much uncertainty. We will have an online webinar, which you're more than happy to join. It'll be based out of only HSS. We're going to try to give you guys what we're doing at the moment at HSS. But then in 2022, I hope, I pray, and I look forward to seeing you all in person. We'll learn some orthopedics, we'll drink some beer, and I hope the world becomes a better place by then. It's great to see you all.
Thank you, sir. Thank you, sir.
so much.
Thank you, everyone.
Great job, Rajshekhar. Well done. And Mallikarjun, thank you. And Roshan, wherever you are, well done. And 3 cheers to KOA for doing this, and keep it flying.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
I think Sheffield has
Hello? You're muted.
Got something to present? I don't know. It's just a 2-minute video about our corporate. I would like to just share it with everyone.
I see it on your eyeglasses.
What, Shafi?
Yes, 2 minutes. It's just opening up. Yeah.
Affection lies in small details. Comfort lies in small details. Confidence lies in small details. Beauty lies in small details. Welcome to Microlabs, where health lies in small details. It was with this core value that Microlabs was incepted in 1973 by the late Mr. G.C. Surana, today Mr. Bimal Surana, and Mr. Anand Surana. Bear the torch of creating a healthier world by making Microlabs a growing, transnational organization. Ranked 10th in descriptions and 20th in sales. Microlabs has a brand portfolio that comprises many top-notch brands in various specialties. We focus on building mega brands which trifurcate into the acute, chronic, and specialty segments. Our numerous products range from oral solids, oral liquids, and topicals to injectables in specialties like cardiology, diabetology, CNS, and many more. The Indian market is a key operating area, reaching out to a large customer base of 200,000 from super specialty to family physicians. Our reach spans from metros to towns, living up to the core value of providing good quality medicines at affordable prices. We believe that affection lies in small details. Comfort.
Thank you, sir. Thank you for giving us the time to present our.
Thank you.
Thank you, everyone. Please.
Thank you, sir. Thank you, sir. Thank you, Dr. Rajshekhar. Thank you, Chandramouli, sir. Thank you, everyone. Thank you, Deepak. Bye-bye.
Thank you, Chandramouli, sir.
Thank you, sir. Thank you.
Sir, we should thank to pandemic. Otherwise, it's very difficult to catch all this busy practitioners, like Deepak, Chandramouli, sir.
Yeah.
And Chakravarti, sir.
Chakravarti, sir.
Thank you so much. Very grateful to have called me. Thank you.
Thank you, sir.
Thank you, sir. You are not seen.
And then,
You have not seen. No?
Your picture or not?
I had kept it muted so that it doesn't disturb the other speakers.
No, it's good.
Actually, I'm very computer illiterate. Chandramurthy, how are you? I didn't get to pull your leg. Next time. Oh, I had kept the video off. I think we should have kept the video on.
Yeah. Then I thought you're not this. You're not this.
No, I thought it was going to interfere with the others. That was the
problem. That's the reason. Okay.
But it was very well organized. Thank you so much. Very nice.
Thank you, sir.
Yeah. God bless you all.
Thank you.
Very good. So take care and good night. And go and enjoy a gin and tonic, which I'm going to do.
Thank you, sir.
Bye, everyone.
Thank you. Bye, sir. See you. Tata.
Shefula, thank you.
Thank you.
Thank you very much.